I'm Dr. John Thomas from Houston, Texas with Solutions Medical Group. We specialize in wound care and have created a true continuum in wound care, taking care of patients from all aspects of the medical community, from the acute care hospital, through the LTAC, through the rehab hospital, through SNF and nursing homes, as well as outpatient wound care centers and home health. Mostly I see in the inpatient setting the acute pressure ulcers, as well as moving into the outpatient setting where they become chronic. Anywhere from stage 4s with bone exposed, with underlying osteomyelitis, to just your regular diabetic foot ulcers and that type of thing in the outpatient setting. There isn't a wound that we haven't experienced. Well, bacteria has a very specific role in wound healing in that it creates a biofilm that can deteriorate the wound and stall the progress of the healing of the wound. This is most commonly seen in the chronic wound, where you'll see the granulation tissue starting to glaze over and flatten out. And it's obvious at that point that the bacteria has overwhelmed the growth of the tissue and has created a biofilm. It's very difficult to rid the wound bed of the biofilm. The most commonly used practice is to use a mechanical debridement, but currently we're trying different topical antibiotic therapies. Been working with PathoGenius for right at a year now. Been very happy with the results I've got from them. They have opened my eyes into new world of how to treat bacterial bioburden. PathoGenius has made a difference in the way I treat biofilm, in that for the first time ever we're actually able to determine what the actual bacteria are that are creating the problem in the wound. I have had patients in the past where we have done culture after culture after culture, and it came up with Pseudomonas, trying to clear the wound, and was unable to get the bacteria under control. It wasn't until later that we tried the DNA sequencing that we found that the true culprit was actually Acetobacter. Only 5% of the bacteria in the wound was Pseudomonas. Once we changed the antibiotic therapy, it changed the outcome for the patient, prevented further amputation. Sensitivity is only specific to the bacteria they're actually able to culture. And not knowing what the true culprit is in the wound creates a further problem for you. So you may have sensitivity to a particular bacterium, but it may not be the bacterium that's creating the issue. So you may be able to clear that one, but did you clear the wound of the bacteria that's creating the problem? Absolutely, it's made a difference in patients' lives and outcome. A particular patient comes to mind immediately was a young man that unfortunately had to get a above-the-knee amputation. We had a wound infection that we could not clear. It became very purulent and starting to show signs of sepsis. We tried and tried and tried with different cultures and with different antibiotics, and every time we kept coming up with Pseudomonas. Finally, we did the DNA sequencing on it, and it did show that Pseudomonas was only 5%, that Acetobacter was the 49% culprit. We changed the antibiotic. It saved him from a disarticulation and healed the wound almost immediately. Well, I think the biggest difference between DNA sequencing and culture is a survival of the fittest. When they put bacterium into a petri dish, they culture it out to a single species. It's not always the species that's creating the problem, but it's the strongest in that dish and in that agar. That's not necessarily what I need to know. The DNA sequencing gives me all the bacteria that are there and the percentages of what I'm dealing with. Through that, we can come up with a combination therapy that treats all the bacteria and gets the entire wound under control, not just the one species.